Good evening and welcome to Doctors on Call. Tonight we're answering your questions about menopause, hormone replacement therapy, osteoporosis, mammograms, and breast health. So what would you like to know about women's health? I'm your host, Dr. Ruth Westra from the Department of Family Medicine and Community Health at the University of Minnesota Medical School, Duluth. Call in your questions locally at 218-788-2844 or toll free at 1-877-307-8762. Our panelists this evening are Dr. Jennifer Boyle, an OB-GYN specialist with St. Luke's Obstetrics and Gynecology Associates, Dr. Brianne Brandt-Griffith, an OB-GYN specialist with Essentia Health, Duluth Clinic, and Dr. Addie Licari, a family medicine physician with St. Luke's Mount Royal Medical Clinic in Duluth. Welcome, everyone. And our medical students answering the phones tonight are Kristen Heslop from Owatonna, Minnesota, Brianna House from Lewiston, Idaho, and Mickey Moran from Sartell, Minnesota. So now on to tonight's topic, women's health. So we're going to start with just some questions before we get the questions from the viewers. So Dr. Licari, let's start with, if I'm 60 years old and I come to the office, what lab tests or screening laboratory work would I have done?
So the benefit of actually going to see your family doctor is to actually get sort of a risk assessment when you come to the clinic. We do go through your past medical history, your surgical history, and then also your family history, which is very important, especially as you age. It depends on your risk assessment, but in general, we are recommending a fasting lipid panel or cholesterol profile, in addition to blood sugar testing in most people who are at risk. Depends on your weight. If you are of a higher weight, we will look at specific diabetic testing if we need to. If there's a family history of thyroid disorders or there are symptoms of that, we may choose to include that, but that's not a standard screening test. So basically it's your cholesterol and your blood sugar screening tests.
Yeah, very helpful. So Dr. Brandt-Griffith, we have some changes in our screening guidelines. So maybe talk a little bit about mammograms and some of the guidelines that we're currently following.
Well, there's three different schools of thoughts for mammograms right now. You have three different organizations kind of telling you three different mammogram strategies. One is the American College of OBGYN. They really stick to the starting at 40 and going every year for a mammogram. Then you have the American Cancer Society, which recommends starting at the age of 45 and screening every 1 to 2 years based on your risk factors. And then the last school of thought is the United States Preventative Task Service, which has looked at the risk and benefits of screening younger women and how doing excessive testing based on mammogram results is more risky for those women. And they've recommended starting at the age of 50 and doing every 1 to 2 years based on risk factors. Now, really, as Dr. Licari said, it depends on your family risk factors. And so there are breast cancer screening tools out there. If you've had a family history of a mom or a sister, you know, first-degree relative with breast cancer, then you're going to want to start a little bit earlier, may add in some genetic screening, or at least get your genetic counselor involved to figure out what your risk is for breast cancer. And then base it off of that. If you get a mammogram and your baseline mammogram says that you have dense breasts, that means that you have more risk of having breast cancer, not because the density of the breasts adds to breast cancer, but because you can't see the breast cancer as well because the breasts are dense. And then you base other risk factors. You know, obesity is a big risk factor for a lot of diseases, and that it's including breast cancer, as well as hormone replacement therapy and a family history, like I said.
Very helpful. So let's go to the other one, which is pap smears. Dr. Boyle, can you talk a little bit about the screening protocols, the new ones that we have out now for that?
Sure, yeah. I think not that long ago we thought every year you needed a pap smear, and that was kind of drilled into our head as women, like every year we need to go to the doctor and have a pap smear. Well, now we still want to see you once a year, but you may not need a pap smear that often. So our new screening guidelines, which came out in about 2012, for women who are under age 30, we only screen about every 3 years. And another change is that we don't start screening until age 21. So I think that's been a big shift So those women in their 20s get screened every 3 years. And then after age 30, you have the opportunity to also test for the human papillomavirus, or HPV, which causes most of the cervical cancers that we see. And so when we have a negative HPV result and a normal pap, then those women over age 30 can actually go 5 years without a pap. And so that's really a big shift, but the science is behind it, and it's allowing us to do fewer tests that we don't need to do. So I think it's a good thing.
How about stopping? You know, we start the protocols, and like Dr. Brandt-Griffith, when would we stop doing mammograms?
So mammograms, typically they say you can stop around the age of 75. But really the bottom line is you look at the longevity of the patient. So if they have a 10-year like a 10-year age that they're going to live, they're healthy at 75, they have no risk factors, then you might want to continue screening, because they, if they do end up with breast cancer, they are not going to have all these comorbidities that are going to affect their outcome. So they might be able to tolerate the surgery or tolerate the chemotherapy. But if you have a patient who is morbidly ill at the age of 65, and screening is only going to add to her morbidity, and now she has this breast cancer to deal with, will she survive the treatment? So it's always a risk-benefit kind of scenario. And it's a discussion with the patient. If the patient is like, well, I wouldn't want to do anything if I did get diagnosed with breast cancer, then you stop screening, because what are you screening for? And the same goes for colonoscopies or pap smears. It's if the patient would not survive the treatment, what's the purpose of screening when a lot of these diseases are very slow growing?
And I think also with pap smears, we kind of have our cutoff at about age 65, because again, that human papillomavirus, which causes most of the cancers, that process takes about 20 years. So if you've had normal paps for the last 10 years and now you're 65, the likelihood of you acquiring a new strain of that virus and actually developing cervical cancer is so low that it doesn't make sense to continue screening.
And I would add, this is the importance of coming to see your physician, because we don't just do a screening test. We screen risk factors, and every person has different risk factors. And so we tailor your treatment based on what your risk factors are. So if you're a 40-year-old woman who might be newly widowed or divorced and have new partners, the screening might be a little bit different for you than somebody who's been in a relationship, with the same person and had a number of negative pap smears. It also might be different for you based on what your body weight is, or what, breast cancer might have happened in your family.
Yeah. And it's important to recognize that screening test guidelines are in general for a healthy population. And so that risk assessment comes in assessing healthy versus not. So patients who have autoimmune diseases or on certain medications that would make them more likely to get an infectious disease, we will continue PAPs every year or every other year based on those risk factors. But our general screening guidelines from sort of the national recommendations are for healthy patients.
Right. And then it's assessed when the people come to see you and women come to see you. What about immunizations? Maybe walk us through immunizations for a woman. Let's go again to over 60.
So in general, in a healthy adult population, a tetanus shot or we are actually updating with tetanus, diphtheria, and pertussis, which is a whooping cough version of the shot, is given every 10 years. So that is a sort of time-based guideline. At 60, we do assess risk factors for shingles, and between the ages of 50 and upwards, we will consider giving a shingles vaccine. Healthy patients at 65 are recommended to get one-time shots for both Pneumovax, which is a pneumonia shot that's been around for years, and a new version of a pneumonia shot that is added to that called Prevnar. So at 65, we assess for those. In patients who are not healthy or have chronic diseases, we would update the pneumonia shots every 5 years.
And I'd like to add, just for Dr. Boyle and myself, practicing obstetrics, vaccines that are important during pregnancy include the Tdap, which is the tetanus with pertussis and diphtheria. And that's not only for the woman themselves, but also for the fetus. So the mom makes those antibodies and passes them to baby. Also, we strongly recommend the flu vaccine when we're in flu season, not only to protect mom, but also protects baby, as baby can't get their vaccines till they're 6 months of age for the flu shot.
And the flu shot actually given to elderly persons or over age 65 is a high dose variant, meaning we actually give a dose that is higher than the typical dose to stimulate more immunity in that population.
And then I think also for pregnancy, like grandparents and anyone who might be around the infant should have the flu.
And just to reassure people, you know, the most common vaccine given to pregnant women is a non-mercury containing or non-thimerosal preservative-free vaccine, and it is not a live virus vaccine. It is a killed virus particles. So people who may have thought that they acquired the flu from the flu vaccine, they just have an immune response. We're not actually giving the flu virus to people. So it's very important to get your flu shot, not only to protect yourself, but to protect those others around you that aren't able to get vaccines.
Yes, especially now, since we're giving them now. It's
right.
a really good idea to get going. So Dr. Boyle, a caller from Superior, asking, I'm 60 years old and had a hysterectomy, but still has ovaries. Does she still need a pap smear?
Good question. No, in general. When you have a hysterectomy for a benign reason, so it wasn't a cancer, then we typically do not do any more pap smears. But I think sometimes patients confuse pap smear with pelvic exam. And so I still feel it's worthwhile to do a pelvic exam periodically where we do a good look at the vulvar skin, because you can get skin cancer there. And also just to check their general health of the vagina that's left, and to try to feel if there's any pelvic masses. You know, usually at that age, the ovaries are going to be pretty small, so we don't necessarily feel them on exam, but we would feel if there was something large in their pelvis. So I think it's still a good idea to have a pelvic exam, and whether that needs to be every year, every couple of years, I don't think there are any great guidelines for that, but she does not need a pap smear.
Thank you. So Dr. Brandt-Griffith, this is about menopause and hot flashes, still having hot flashes and wondering what there is to alleviate it. Has anything come out differently than what we've been using in the past? It's a big question.
Yeah, there's not much that's different than that was in the past. You know, the Women's Health Initiative did the large study on hormone replacement therapy in women, and data is being reviewed about that and the safety of hormone replacement therapy in women. Big things are just, you know, on baseline are just lifestyle changes. So exercise has been shown to decrease hot flashes. Things that you can modify, like the temperature in your home. They have cooling blankets, cooling mattress pads, fans. Those have been shown to alleviate menopausal symptoms, hot flashes. A step up from that, if you were concerned about starting hormone replacement therapy, are some of your antidepressants, which we also use for hormone type issues, whether it be depression, insomnia, hot flashes, can be beneficial, and so that at low doses can be effective. And then we talk about hormone replacement therapy. Now, the big concern with hormone replacement therapy is, you know, you're starting something that definitely has the increased risk of blood clots, stroke, breast cancer, but it varies based on the dosage, how you're dosing it, whether it be oral or transdermal, because there are patches. Also, we have vaginal suppositories that we can use for vaginal health and some sort of systemic absorption through the vagina. So it really depends on, once again, back to what the patient's risk factors are, and whether it would be, you know, what would be the best for her and what she feels most comfortable with, you know. And some women, hot flashes are short-lived, and other women, it lasts for quite some time. So it depends on what she feels most comfortable with.
Absolutely. Well, Dr. Licari, I have a caller asking about screening for ovarian cancer. Do we have any screening tests for ovarian cancer?
The answer is mainstream, no. We do not have a test that is being used in general for screening low-risk populations for ovarian cancer. There has been some research into a particular laboratory value combined with a pelvic ultrasound, which is an ultrasound done vaginally to look at the architecture of the ovaries. And that is mainly in higher risk populations. I believe we're studying it and sort of looking at, well, what is the cost benefit to doing that? We would do a lot of testing to discover one ovarian cancer and sort of how many follow-up tests would be needed for findings that maybe were slightly abnormal. Mm-hmm. So we do not have a general screening for ovarian cancer, which is why talking with, listening to Dr. Boyle, that pelvic exam is what most primary doctors and obstetricians are using for ovarian cancer screening.
Yeah, unfortunately, it's often a bad cancer when people have it because it's found late, because we just don't have a good screening test. But on the flip side, it's very rare. Mm-hmm. I think it's 0.7% over your lifetime that you have risk of having that. So,
good. How about Dr. Boyle? Talk to us a little bit. A couple callers are asking about incontinence, and why does that occur as you get older?
Well, there's several different types of incontinence, but the two main types that we see are stress incontinence and urge incontinence. So urge incontinence is maybe the commercials you've heard, gotta go right now. And that's when the bladder, which is a smooth muscle, contracts when we don't want it to. And so then we have this bladder spasm, and if we don't get to a bathroom in time, we might leak. So that's kind of one form of incontinence, and that's often treated with medication. The other type, stress incontinence, that's more if people cough or sneeze or have some sort of increase in their abdominal pressure. And based on their anatomy, perhaps they've had obstetrical trauma, or their pelvic floor is weak, their bladder neck moves too much when they have that increase in their abdominal pressure, and they can leak. And so that is more of an anatomical problem, and so often we're actually sending people to physical therapy a lot for that, where they work on those pelvic floor muscles, the Kegels, and that kind of thing, and making sure that they're doing them correctly, and that helps a lot of people. And then sometimes we'll actually place a little sling underneath that bladder neck that gives a little more support. So it's not really tightening up, but it's just giving a little backstop, so when they have the cough or the sneeze, the bladder neck doesn't move as far.
And I think it's important to note that in general for incontinence, avoiding alcohol or regular alcohol intake, limiting caffeine, and staying a healthy weight can go a long way to helping with incontinence.
What about, Dr. Brandt-Griffith, about abnormal bleeding, maybe irregular periods in menopause? Are there any things that we can do to help if the bleeding gets too heavy?
So once again, it depends on your risk factors. I know we keep going back to this, but in our day and age, obesity plays a huge risk factor in risks for disease. And so if a woman has lots of risk factors at the age of 30 and having irregular bleeding, it's important to get an endometrial biopsy to make sure that there's no abnormal cells, no risk for cancer for her. Now, if you have a lot of women in perimenopause, so right before they transition into menopause, will have irregular periods, heavy periods, painful periods. I like to say that they've gone kind of back to their teenage years. We all remember when our periods started and they were heavy and painful, and similar treatments that we used in our teenage years we use in our premenopausal years. So those can include birth control pills if they don't have elevated risk factors for heart disease or stroke or blood clot. Those can include progesterone only options, which don't include those risks or don't increase those risks of stroke, blood clot, and those can include pills. IUDs are very effective in helping with irregular bleeding. And then we also have surgical options. And as you go up that treatment pyramid, your risks increase. And so you have endometrial ablation, which is burning the inside lining of the uterus, and then you have your surgical treatment of a hysterectomy. Now, obviously, we'd want to get a biopsy of the uterus to make sure we're not missing anything before we go and do a surgical procedure. But there's definitely a whole array of options.
Very helpful. So I see everyone's dressed in purple. And so, Dr. Licari, can you explain part of the reason why the color purple?
Well, we happen to all be wearing
I
purple
know.
today. But it is Domestic Violence Awareness Month, and the color is purple, and I believe Ingrid Tower is actually being lit up in that color as well.
Tonight.
Tonight.
Yeah.
So maybe a little bit about what questions we would ask a person, a woman coming to the office, so that we could help to screen potentially for somebody at risk for domestic violence.
You know, I don't know how it is in your office, but we have kind of an intake form that asks their past history and their pregnancies and stuff. And then one of the questions is, do you feel safe? And have you had any abuse? And so if those questions are marked, then obviously we'll talk to them. And you know, if it's pretty rare for somebody to come forward and tell you that initially. But if you ask and say, are you safe where you are? And you know, sometimes we see red flags too, where often if the partner is there, they won't let the woman talk, or it's a weird dynamic. And so you can kind of pick up on things like that too. And you know, hopefully take the woman aside and talk to her and see if she's safe or if she needs help.
Very helpful. Dr. Brandt-Griffith, the caller from Virginia. So this one's asking about talcum powder. Any relationship with talcum powder to any of our women's cancers?
Well, there was a study recently that talked about the link between talcum powder and ovarian cancer. And I'm sure the question is probably stemming from some of the ads that they've seen on TV about talcum powder and ovarian cancer. You know, we screen for it, but there's not any, we don't increase our screening. We don't increase the number of ultrasounds we do or any kind of lab tests. It's just kind of a marker on their sheet if they've used it, whether they've used talcum powder in the past and their risk of ovarian cancer. But it definitely, the risk of surgery, of like taking out ovaries and being that invasive, that risk outweighs the risk of using a talcum powder, you know, throughout your life.
A caller asking Dr. Licari about DEXA scans. When would we do DEXA scans, or when should she have one done?
So in general, we again look at risk factors, and so we might even start in someone who has gone through menopause in earlier life or earlier than the age of 47, 45. We might start to get a baseline at that point. We also would look at family history. So if we have someone whose mother had severe osteoporosis, we would look at screening in the late 40s or 50s at that point. In general, for healthy persons, we're recommending around the age of 65 doing a baseline bone scan. And some of the reasons for that are the estrogen that is sort of floating around our bodies through our adult life, combined with your dietary calcium sources and your vitamin D, are actually protective up until menopause and even 5 to 7 years afterwards. So what we're looking for is how you've done after menopause when your hormones start to wane and you don't get that protective effect any longer. And then the frequency of DEXA scans obviously depends on the results of that DEXA scan.
Have we come up with any definite recommendations on vitamin D and calcium for women? Anybody can answer if you... I know it's been kind of up and down.
Yeah,
I mean, I usually tell my patients we're in a climate where you don't get very much sun here in Duluth, and so I think that most people would benefit from a general supplement. So I just don't know that we get enough from our own, you know, sun sources.
We've really gone back on the calcium, on the high doses for calcium in the general population, because there have been some studies that have shown not only that we've super supplemented calcium without a benefit in osteoporosis throughout a period of time in a population, but also that we may be doing some, there's some trends in doing some harm regarding calcified vessels and coronary artery disease risk factors.
I think the baseline too is that the best way to get calcium is through diet.
Right.
You know, having a healthy diet, you know, taking in your milk or cheese or yogurts, because that's going to be the best processed in your body. And then vitamin D, the studies show anywhere from 600 international units up to 2,000, 5,000 international units based on where you're at. In general, you know, our office says, you know, take 1,000 international units just because we are a climate that doesn't get a lot of vitamin D. And a recent study just came out saying that vitamin D over the winter, supplementing with that actually helps with fat burning and reducing fat storage over the winter. And perhaps that's why we have such fat storage over the winter, because we don't get that vitamin D. And so that's the importance as well, to take your vitamin D over the winter. You don't store up enough over the summer here in Duluth to benefit for the winter.
Yeah, and it's important to note that the studies done on vitamin D are done throughout the United States, and so in places where they have good adequate sunlight, and there are several months out of the year when we do not have adequate sunlight.
Yeah, I think that's very helpful information because we all probably are saying different things. It's one area that we don't probably have exactly the amount that we want people to take, but
well, even if we're in the sun, then we're in sunscreen.
Yeah,
right, exactly.
There in general is a recommendation against general screening of the population for vitamin D deficiency. So I'm recommending most of my patients take it and not check that level.
And not do the level.
Yeah.
Well, that's very helpful. This time has gone really, really fast. I'm just going to ask one real quick question. HPV immunizations really are not for adults?
Right now they're recommended for people, not just girls, but boys also, ages 9 to 26. So
very good. Well, thank you.
And the reason being is because the FDA only did studies on 9 to 26-year-olds, so they didn't study the older population.
Cool. Well, we have to wrap it up here now. So I want to thank our panelists, Dr. Jennifer Boyle, Dr. Brianne Brandt-Griffith, and Dr. Addie Licari, and our medical student volunteers, Kristen Heslop, Brianna House, and Mickey Moran. Please join Dr. Ray Christensen next week when he'll be discussing men's health and kidney stones with his panelists, Dr. Rebecca Beach, Dr. Steve Teacup, and Dr. Paul Tonkin. Thank you for watching. Good night.